Hi, this is Ali Jazieri. I'm a first-year cardiology fellow at the University of Kansas, and I'm joined here at the American Heart Association 2017 Scientific Sessions by Dr. Zuzana Motovska from Charles University, who's a professor of cardiology in Czech Republic in Prague. We're here today to discuss the long-awaited results of the PRAGUE-18 one-year outcomes. And first of all, welcome, Dr. Motovska. And I'd like to ask you if you could briefly tell us what the results of the first PRAGUE-18 trial were and what you were looking for in this follow-up study.
Thank you very much for invitation. So the PRAGUE-18 study was the first and for now the only completed randomized comparison of prasugrel and ticagrelor in patients with MI treated with primary PCI. So the early outcomes did not find any differences between the two drugs. The study has a superiority design, so the difference between the two drugs did not confirm the hypothesis that one of the new drug is more effective or safer than the other one. So, and 1 year follow-up focused on a comparison of both drugs during the whole study period, during the 12 months follow-up, and also on an economically motivated post-discharge switch to clopidogrel. Our study was a purely academic project. There was no support from the industry. Therefore, after discharge, patients have to pay out-of-pocket money for study drugs. Based on a study protocol before discharge, patients were informed about the out-of-pocket cost for prasugrel and ticagrelor, and they also discussed with their treating physicians about the long-term benefit of treatment with prasugrel or ticagrelor compared to clopidogrel. So based on the protocol, it was allowed that patients who were not willing to accept the co-payment for study drugs switch to clopidogrel. And 1 year results show that during the whole study period, there was no difference in key efficacy endpoint, which was cardiovascular death, non-fatal MI and stroke. There was absolutely no difference in risk of bleeding, and also patients who were economically motivated to switch to clopidogrel had, when compared to patients who continued their study medication, significantly lower risk of efficacy endpoint. Substitution of new drugs with clopidogrel resulted also in a significant reduction of bleeding risk. However, also on the other hand, patients who were switched to clopidogrel for other reasons than economic have a very high risk of ischemic events. So our results contributes to an individualization of antiplatelet therapy in MI. That means approach which assesses the risk of bleeding and ischemic risk in one patient.
Thank you very much for that explanation. If it's all right with you, one of the criticisms of the original PRAGUE-18 trial as it was published was the sample size and concerns that perhaps it was inadequately powered to assess the study question. I'd like to get your thoughts on that, and also to see if there was any influence from that criticism on the current study that's being presented at this conference.
Okay. So needed sample size based on power calculation was estimated at 1,250 patients in each study arm. The study enrollment was stopped prematurely because of interim analysis after randomization of 1,100 patients. So real difference in the occurrence of primary endpoint did not reach the minimal level of statistical significance in any part of enrollment period. Moreover, with growing number of randomized patients, the difference stabilized at around 0.1%. And this difference is absolutely clinically irrelevant. The occurrence of primary endpoint in patients treated with prasugrel were 4.1%, and in patients treated with ticagrelor 4.0%. So we stopped this the enrollment prematurely because we think it will not change.
Thank you very much. So now that the one-year outcomes are released, I'd like to get your comments on how you think that this might influence practice moving forward, specifically given the target audience of this blog as fellows in training. How do you think current fellows who are training should take these results and incorporate them into their developing practice?
So after the Triton and Plato studies were published, the landmark analysis pointed to a high efficacy of prasugrel in very early phase of myocardial infarction, and the results between ticagrelor and clopidogrel in STMI from the Plato study were not very positive for ticagrelor. However, our study showed that there is absolutely no difference. I mean that the physicians can choose prasugrel or ticagrelor. There is no difference in efficacy. There is no difference in bleeding. And the one year outcomes we can use as a model of a safe de-escalation of prasugrel and ticagrelor to clopidogrel based on patient-related risk and procedural results, because when we compared patients who switched to clopidogrel for economic reasons and those who continued the study medication, we saw that patients who switched had significantly lower presence of bundle branch block and acute heart failure at admission, and they also had significantly lower left main disease and unsuccessful PCI. So when we use this model with this characteristic to our decision for the escalation, it seems to be safe. However, our results about the escalation were not results of randomized comparison. This is a concept which has been proved in a randomized study optimally.
Thank you for that explanation. It's also my pleasure to have you here as we're sort of celebrating the 20th anniversary of Women in Cardiology. I think you are a prime example of a successful woman cardiologist, and I'd like to get your thoughts about what advice you may have for women considering a career in cardiology, and in particular a career in academic cardiology.
I am not sure if I am in my heart the person who is supporting women in cardiology. I think there is no difference between women and men in cardiology, and good women will be good cardiologists except of female, of a gender.
Absolutely. Thank you very much. For more videos like this, please go to www.youtube.com/FITSontheGO.